Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello, everyone, and thank you for tuning in to this episode of the Doc Podcast. I have the great pleasure of introducing today's guest, the very impressive Nicole Goldfarb. Nicole is a speech-language pathologist and certified orofacial myologist who graduated magna cum laude from UC San Diego with a bachelor's degree in psychology and then went on to receive her master's in speech-language pathology from San Diego State University, where she was selected as the outstanding graduate student by the Department of Speech, Language, and Hearing Sciences. She founded the San Diego Center for Speech and Myofunctional Therapy in 2003 and is one of only 3 certified orofacial myologists with a master's degree in speech language pathology in all of San Diego. Nicole received the American Speech, Language, and Hearing Association's ACE Award for Continuing Education from 2009 to 2012 for her advanced number of professional development trainings in the field of speech language pathology. She has a passion and interest in sleep disordered breathing in particular, and its relationship to myofunctional disorders. And she's presented on this topic nationally and internationally. Nicole combines her background and skills in psychology, orofacial myofunctional therapy, and speech language pathology to provide effective and result-based therapy for children and adults of all ages. With that, I would like to extend a sincere welcome to Nicole Goldfarb to the Doc Podcast. Welcome, Nicole.
Thank you so much for having me. I'm so excited to be here.
Yeah, no, thank you so much for coming on. And as you read through that, people are probably thinking, if they're not super familiar with those words, like, what the heck did he just say? The different degrees and trainings, and so it's. I want to start by talking a little bit more about kind of what your area of expertise is, and get into a little bit of detail on what you actually do, because I think I know it's widely misunderstood. Until I got into this arena, I didn't really understand what it was, what exactly a speech language pathologist did. Compare that to orofacial myology, and do they same degree, different degree, do the same thing, different things, and what makes one versus the other. So how did you get into this first? And then we'll kind of use that to springboard into what exactly all these different terms and specializations within your field mean.
Right. It can be so confusing with all these words and titles and, what is everything. So I will definitely clarify. So I did get a graduate degree in speech language pathology. So that is what I'm licensed in. That's my profession.
Okay.
But I got special advanced training in a modality called orofacial myofunctional therapy. So orofacial myofunctional therapy is the same as myofunctional therapy. And I can call myself a myofunctional therapist, an orofacial myofunctional therapist, an oromyologist, right? They're all mean the same thing.
Okay, good.
And those are just a type of treatment approach that falls within the realm of other licenses, like certain people who have the training in the dental hygiene field, or some physical therapists might have myofunctional type training, or occupational therapists. But the majority of the specialists who have this training and seek this advanced training would be speech therapists or dental hygienists. And by the way, speech therapist is the same thing as speech pathologist or speech language pathologist. That all means the same thing.
Oh, thank you for that, because I know those get used a lot, and so that speech therapist, speech language pathologist, and speech pathologist are synonymous, effectively.
Exactly. They all mean the same thing. It just sounds fancier, maybe if you say speech language pathologist, but speech therapist.
Or SLP, I know a lot of people abbreviate it as, right?
SLP, exactly, because it's a mouthful to say.
Yes.
So I was a speech therapist for about 7 years working in a school district, and I had no training in myofunctional therapy or facial myology. None of that is in nearly every graduate program in speech therapy. It's not part of the graduate program, right? Kind of like you think like, many or almost all orthodontic programs and dental programs probably don't have airway training, right? Similar thing.
I was gonna say literally that after you finished, I was gonna say, geez, it reminds me a little bit of orthodontic and dental training and airway. So yeah, you're right on.
Weird, right? There's so many like mirrored things here. And it was funny because I remember on the graduate exam to receive my licensure, there was a question about what is ankylosing. And that wasn't even something we really learned much about in graduate school. Like I was like, okay, let me break apart the word versus like, oh, it's like right now, that's like one of my favorite words. So it's kind of funny because it was not in our graduate program training, really. We didn't learn much about nothing airway.
Is that still the case?
Still the case. There's maybe a few programs that are beginning to incorporate this. And I did just see a Facebook post from one of my wonderful colleagues, Robin Walsh, who is now going to teach a course in a graduate program. I forget which state.
Okay.
So that's like, wow, that's new. That's amazing. So it's not really in most speech therapy graduate programs. Okay. So when I worked in schools, performing speech therapy services for about 7 years, noticing that a lot of these kids with speech articulation issues, like maybe a lisp, or they say the R sound wrong, or a variety of different sounds wrong incorrectly, are also have these like large tongues, or the tongues look kind of large. Oh, wait, the mouth is kind of open. These kids have this similar facial feature, right? And we're doing like drill and kill, pulling them from class once or twice a week, every week in small groups, just drilling the speech sound. So the list might be like the tongue sticks forward interdentally for an S sound.
Yep.
Like house, they might say house. Right.
Okay.
And so we just keep drilling the word and the phrase and the sentence, and they're getting better, but it's not fully carrying over to conversation when they're not thinking about it to like a subconscious, unconscious level. Right. And I learned about myofunctional therapy because there was somebody in the area who was a myofunctional therapist here in San Diego, and I knew what it was. But at that time, I did not know that we could say, I've heard numbers saying about 81% of children with speech articulation issues also have concomitant myofunctional issues. And if you don't treat the myofunctional issue, the speech issue may never fully resolve or may take years to resolve.
And for those who aren't sure, myofunctional meaning it's muscle related. There's some sort of muscle imbalance. Would that be correct?
Yeah, and I will describe what that is. But at that point, I realized, that's why these kids are getting pulled from class for years and years and years, because we're not treating the underlying cause of the problem. So orofacial myofunctional therapy, or orofacial myofunctional disorder, if you break it down into its components, oro is mouth, facial is face, myo is muscle, and function is what those muscles do for the 5 basic tenets of the mouth. So oral rest posture, so the way our lips and tongue and our jaws, our dental freeway space is when our mouth is not moving, so that rest position, and chewing and swallowing of foods, liquids, saliva, and then also how we produce our speech. And so those are kind of the functions of the mouth. And an orofacial myofunctional disorder is when there's a problem in any of those domains, and those are underlying soft tissue dysfunction, so muscular issues. And as the myofunctional therapist, we need to treat any underlying or related problem that is causing the muscles of the mouth to not function and rest correctly. So I did a training. This was back in 2008 through the International Association of Orofacial Myology with Joy Moeller, Leisha Pasquet, and Barbara Green. I took a course then, and my life changed. I never looked back. My whole career changed in the way I practice speech therapy, but also I almost feel more importantly, the way I did my evaluations and the way I looked at patients and students. And then I always think the way I looked at my family, my friends, myself, everybody in the world.
It's inevitable.
Like,
So it took it from SLP, speech language pathology, which is essentially what you're saying was more of a, much like orthodontics, I will say, tends to be a reactive, treat the issue based profession, right? You're trying to help them get better with some challenge or problem that you're seeing, as opposed to when you get into the orofacial myology, you're looking more etiologically at things and trying to figure out the why and then addressing that. Would that be fair?
Not necessarily. So speech pathology, we are always looking underlying issue, addressing the why. But with speech articulation cases, a lot of times the why has to do with some myofunctional problems.
Okay.
And that's a component that speech therapists should be trained in and should be taught and should understand. Otherwise, you're missing a big piece to the puzzle as to why a lot of children and adults, their speech issues might not easily be resolving or might be persisting.
Okay.
But the field of speech pathology is a very detailed, very high level field that entails all different domains. So not just speech articulation, but language, expressive, auditory processing, receptive language. We work with patients who have brain injury, dysphagia, so swallowing issues, stuttering, we call it stuttering or fluency, voice issues, so issues with the vocal folds or the way people present their voice, and social pragmatic language. So there's so many different realms to speech pathology, but when we're looking at that sort of articulation realm and some of the swallowing issues, myofunctional therapy is a treatment program to help rehabilitate core muscle function and rest posture in those domains. And the way it relates to speech issues oftentimes is if we're thinking of a lisp where someone thrusts their tongue forward, and we've all heard that, right? Or sometimes the sound tends to be slushy, like bus might say but like kind of like daffy duck, right?
Yep.
So that relates because the way our tongue muscles, our lips rest impacts the movements of them. So posture is the foundation of function. And every movement is determined to a greater or lesser degree by the posture in which that movement began and the posture which it returns.
Okay.
And I love that quote, and I kind of memorized it because if you think about it, if someone rests with a low forward tongue posture, they're not going to lift their tongue up behind their teeth to make an S sound, which is the correct positioning. The tongue is just going to follow that normal resting and thrusting position. So we want to correct posture first and strengthen muscles and strengthen the muscles for chewing and swallowing before we want to rehabilitate the speech aspect of it.
Okay.
So you can say that the lisp or the speech issue is just oftentimes a symptom of the underlying orofacial myofunctional issue. So kind of like that's how I got started, changed so much of the work I was doing. And then I started working more specifically just in the myofunctional therapy realm.
Could you use those techniques in the school, or was it,
that is a little tricky. It is a little tricky because schools have certain requirements where the issues need to be related to usually academic performance and affecting the child's either ability to perform at grade level. They need to have certain developmentally lower scores in areas.
Okay.
And they treat not so much medically based issues. So a lot of schools consider breathing, swallowing, or rest posture as a medically based issue.
Okay.
That doesn't mean you can't treat it, but it just kind of gets to be a very gray area. And the type of program of myofunctional therapy is not like 30 minutes. You come to my office once a week, do these few things.
Yep.
I'll see you next week, right? Yep. This is like, we always have the parents sitting right next to the child. And in a school, you couldn't do that, right?
It's not conducive to that, yeah.
No, in our office, the parent must be there because they need to practice every single day for a certain amount of time. And the parent needs to know exactly what they're doing, how they're doing it, to be able to help guide that program. Yep. So you can utilize like techniques in the schools, but it's difficult, especially because a lot of school-based speech therapists don't have that training to begin with.
Sure.
So, and it also gets really touchy because you can't really refer out when you work in a school, because then you're holding the school liable for funding a service that you're saying that student needs in order to be successful in the academic setting. So it gets to be very tricky. I stopped working in the schools and started private practice. Saw all different types of children and adults, not just myofunctional therapy, but all different cases. I loved kids with autism and Asperger's syndrome. That was like my love, love, love. And then I started branching off just in the myofunctional therapy realm because it just became so prolific to me and my children having these issues. And it just started becoming something where I just was fascinated by and just became a passion. So then looking back, I thought, oh my goodness, how many kids did I miss?
Right, right.
Pulling them from class, right? It's like there should be a word for this, like therapist guilt.
Yeah,
When you open
yeah.
your eyes and you learn more, and then
Yep.
you
Orthodontists
could
have the same guilt with our cases. Exactly. Yeah.
we need to have like a group, like a therapy guilt group for us all to like vent, because I'm sure you have the same thing where you can actually probably think of specific patients
Oh yeah. Yep.
that you're like, can I call that person and
Yep.
like what they're doing and how, because we missed. And yeah, I have specific people in my mind where I know that I definitely helped, but I was missing something. And
Hmm.
you know,
Yeah.
time has gone
It's
by.
now, how do they? So once you go into the private practice realm, if it's not coming from the schools, and this may have changed from back then, but how do patients get to you? How do they even know to go to you? Who are your main referral sources, and how do we? Is it through just public education? Is it through the dental office? Where do they? How do they know?
Yeah. So I would say back in like early 2000s, when I worked with somebody I consider my mentor. She was like my soul mother. She was a myofunctional therapist, the first and probably the only certified orofacial myologist at the time here in San Diego. She did this for 40 years.
Okay.
Her name was Katha Fair. She moved to the East Coast. She's amazing. Everybody knew of her. And so parents would take their kids, or adults would go to her office and drive. She was kind of far away, but they drive over there for therapy there. And her referral sources were mostly dentists and orthodontists.
Okay. Interesting.
And the mindset was treating for the occlusion reasons. So knowing that soft tissue dysfunction is a major contributing factor, if not primary causal factor, to dental malocclusion.
Yes.
You can ask people like Dr. Herman Ramirez, Kevin Boyd, tons of people, and they'll say, Dr. Derek Mahoney, they'll say that all orthodontic cases need a myofunctional therapist on the team, and that soft tissue dysfunction is the cause of malocclusion. Now, we know there's genetic components, right? But the oral facial muscular system impacts the way the jaw bones grow, and the alignment, plays a role in the alignment of the teeth. So at that time, the referrals were mostly dentists and orthodontists. And it's like, oh, Joe Schmo has an anterior open bite. Can we resolve the tongue rest posture and thrust?
Got it. Sure.
Get
Yep.
braces, the braces
Yep.
will work. Right? So that was the whole perspective. But Katha always noted, she took diligent notes, like probably a lot of us, like type A, like write everything down. Like,
Yep.
she noted, and it was actually before a lot of things were on the computer. So it's all like paper written files and charts. And almost all of her patients, she had notes saying, oh, by the way, Katha, I don't snore anymore. By the way, Katha, I feel so much better. I wake up so much more well rested. And all these notes about that, but it wasn't
And this is
about
about after how long, and kind of generally, you don't have to get specific, kind of what was she typically doing for them in that period, and about how long was it taking until she was noticing that?
Well, it was a myofunctional therapy program, restoring correct oral rest posture, getting lips closed, so nose breathing
Okay.
24/7,
Yep. Yep.
right?
Yep.
During wakefulness and sleep, getting the tongue up, not for the purpose of changing the occlusion, not for the
Right.
purpose of helping breathing or sleep.
Right.
The icing on the cake where all these other things happen, right? And a lot of dental cases, orthodontic cases, the open bites would just close because the tongue pressure was
Sure.
moved, right? But she was noting throughout the courses of therapy with so many patients that they would report side notes or side effects, like they're not snoring. So then as time went on.
You know what's so interesting about that, Nicole?
Yeah.
That's exactly how I figured out I was having an impact on airway. Exactly. I was treating the etiological component in my patients, which was a transverse deficiency, right, of the bone and or arches. And I was doing it because we were taught extract teeth, as most orthodontists were 20 years ago and still are today, for these narrow, crowded kids that are young. And so I was just like, I'm not treating the etiology here. There's something wrong with just going in and removing teeth on a patient whose arches are this narrow, because the teeth are the symptom. They're not the etiology. The etiology is the transverse deficiency. So I started addressing that. And exactly like you were just saying, I started having patients coming back saying, Dr. Mike, do you think it's related that like he doesn't snore anymore? Or do you think it's like a coincidence that a few months after we've been expanding, like I don't know, they're kind of acting different. They're not as hyperactive. I mean, and it probably took me I don't know how many dozens of times I had to hear this, kind of be beat over the head. At first, I'm kind of, because I was trained, not that wasn't a thing. So I'm like, I never learned that. And we are victims of our training and our education. And the more of it we have, sometimes the more we become dogmatic on things, because it's like we become myopic. And so I was just like, well, maybe, I don't know. And I really didn't know. And at the time, I guess a fault of mine, I didn't really go research it as much. I was building my practice. I was busy. But after a little bit, and especially when I got my 3D iCat, and I suffered with a lot of airway issues myself, allergy based with sinus surgeries and everything, and challenges nose breathing. So I maybe was a little more sensitive to it, but it was like this light bulb went off, and I was like, whoa, wait a minute. Once I could especially see before that a lot of these kids that I was expanding that were narrow had these high vaulted palates and these restricted nasal passageways and turbinate hypertrophy and enlargement of lymphoid tissue and narrow oropharyngeal airways and insufficient tongue space. And it was like all of a sudden it started flooding me. I'm going, oh my gosh, wait a minute. When I'm making room for their tongue, it helps posture it better, and it helps the growth and development of the face. And it all just started coming together in that exact same way, completely analogous, as you were saying. And I'm like, that's so interesting that she had the same sort of evolution in her thought process.
Right. But it's not research, right? Because we see in our patients, it doesn't count. No,
right.
Joking. But yeah, I remember like there's a case, and it's in one of my slides when I do certain presentations, but she talks about this one boy, Lucas, who was 9 years old, who would always wake up in the middle of the night, go into his parents' bed, thrash, toss, and turn, kick, and then he'd wake the dad up. So the dad would go sleep on the couch. And the mom said, throughout the course of therapy, Lucas is not waking up anymore. He's sleeping through the night. And so the whole family is sleeping better.
Right.
So this kind of, was a side effect of restoring correct oral rest posture, right? So now, as time has passed, I feel like for me, referral sources aren't just dentists and orthodontists, but now there's more ear, nose, and throat doctors, oral maxillofacial surgeons, but also a lot of patients self-referring because they are learning about this through social media, through books like, the book Breath by James Nestor, through all different
through podcasts,
podcasts, right? Through podcasts, all different ways. And they're starting to learn about this and realizing, I have this problem too. Oh my goodness. Or my child does. And I get so many referrals from a patient self-referring through the internet or learning about it.
So people can just show up to your office or someone who does this. They don't necessarily need a gatekeeper medical referral for this. Is that true?
Right. It depends on who the specialist is. So like I said, myofunctional therapy is just a modality of treatment. So you go to a provider based on their primary licensure and what they're allowed to do within that licensure. So if you go to a speech therapist or a speech pathologist, you have to make sure that speech pathologist is trained in myofunctional therapy. Okay. So you wouldn't just go to any speech therapist. You would want to make sure they are trained in myofunctional therapy, are a myofunctional therapist. And then it depends. Does that speech therapist take insurance? If they take insurance and are in network with insurance, does your insurance require a referral? For me personally, I'm not in network with insurance. So I provide my patients with super bills, which is an insurance receipt that they can submit, for out of network speech therapy. There's no insurance codes for myofunctional therapy. It's not a licensure. Most insurers don't even know what you're talking about, or turn a blind eye and say, oh no, we don't cover myofunctional therapy because there's no codes for it. Okay. So what you are writing an insurance super bill for or billing is what you're licensed, a speech therapist. So it would be speech therapy codes that I would put like for the ICD and CPT codes for an insurance bill. So insurance sees it as speech therapy because I'm doing speech therapy. I'm just doing a modality that I'm trained in within. So there's different specialists that have different roles on the team, depending on what their license is or primary license, what they're trained in. My office, we work with a lot of physical therapists who have some training in myofunctional therapy that treat whole body aspects, posture.
Interesting. Okay. Yeah.
Yeah. Different components. So we actually team up on the cases, and it's been really amazing. So for you don't need a referral for myofunctional therapy for most providers if they're not in network with insurance, like that. So yeah, it's just a matter of finding the right people, the right providers, and who know what they're doing. You need that training and the years of experience to really grasp it. And it's a never ending learning process. So somebody who's maybe just taken a course and is, new, is probably not going to know as much as somebody
Mhm.
who's been doing it for many years, although they might both call themselves myofunctional therapists.
Okay.
So you could just take a 20-hour course and say, oh, now I'm a myofunctional therapist, but it
Okay.
doesn't give the same training as somebody who's maybe done it or done more courses or a different length of time treating patients. So
Got it. Okay. Okay. And I
it's a learning process.
appreciate you explaining that, because I think just helping people understand these terms, not just in the audience that I have for the show. A lot of it is professionals, but I have a lot of parents and people who follow the show, and there's just confusion around all of this. And I was the cleft craniofacial orthodontist on a team, worked intimately with speech pathology, and was so amazed by the things they did. And I mean, she was like Jackie, who was the main one on our team. She was literally the ENT's like right hand. I mean, she was, they worked together with swallow studies, and like you said, everything of analyzing every part of this patient's speech and mastication and swallowing. And it was just fascinating to watch how much of a role the speech pathologist plays in all of this. And I still didn't know the specifics until I learned more about it. But at that time, I didn't know much about the difference in kind of oral myofunctional therapy versus speech pathology. So I appreciate you taking the time to break that down, just so everyone can kind of have a baseline understanding. So then once that patient comes to you or to someone who is specializing in this and able to help the patient, let's just take a younger kid, like a 4 or 5-year-old patient at this point. Could you give an example of kind of what you would do? You don't have to get extremely granular into every little thing, but kind of a general view of what does that process look like? How long does it take? What type of commitment does it involve from the patient? Like kind of how much homework and practice, like with PT type of exercises? If you could talk us through that, that'd be great. Hey, everybody, be sure to check out the Doc website, where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode.
Yeah. And what I think is the most important is the evaluation.
Okay.
So we take about 1 to 2 hours in each evaluation, because you need to find the underlying cause or all of the contributing factors to what is causing the tongue to not rest in the correct position.
Yep.
What is causing the person to have open mouth breathing, if they do? And I always like to clarify, not all myofunctional disorders entail open mouth breathing, or we can say mouth breathing. There's a lot of patients who sit with their lips closed, yet their tongue is not resting in the correct position. So their tongue might be resting low or forward or spreading at the sides.
Mm-hmm.
So it's not all mouth breathers that have this issue. So we start out with the evaluation, and I like to break it down into 3 interacting systems when we're looking at the causes of myofunctional disorders, because it's nearly always multifactorial. There's never one problem. There's never one cause.
Again, just like airway, right? It's almost always multifactorial, right? Same.
Exactly. Yep. There are so many components usually, especially when such an issue's persisted over time, because we develop compensations. So now there's many underlying factors, contributing factors. So my mentor, Katha Fair, who I love so much, taught me that there's 3 interacting systems, and somehow this just clicked. And I swear I'm going to develop a presentation on this one day because it's so good, because it makes it black and white. The medical system we must look at, the dental system, and the myofunctional system. And they're just 3 overlapping circles, almost like the Olympic-like circles, but just 3 of them overlapping. So we want to look at factors within the medical system that may be affecting how the muscles work. That might be issues with the nose, like deviated septum, enlarged nasal turbinates, congestion, allergies, recurrent illness. We might go back further, that enlarged adenoids, enlarged tonsils, right? Tongue tie, anything in that medical system that may impact how the muscles works need to be addressed. The dental system is like the dental skeletal system. So if the palate's too narrow to allow the tongue to rest correctly, sometimes dental appliances impact where the tongue rests. Sometimes palatal torus is so large that the tongue can't rest in the correct position. So sometimes the occlusion is so bad, like a significant class 2, that the patient can't easily get the lips closed.
Sure. Yep.
Right. So we have to look at factors in the dental skeletal system that affect the way the muscles work. the orofacial muscles, and then the myofunctional system, the muscular system. So are there oral habits like thumb sucking, chewing or biting or sucking habits? Are there problems with weakness of the lips? Problems with overdeveloped genioglossus or tongue thrusting muscle? Are there chewing dysfunction? They only chew on one side. Do they spread the tongue when they chew? Right. So we look at all those systems, and in the evaluation, we attempt to identify as many contributing factors that are causing or contributing to the poor oral rest posture and chewing and swallowing issues.
Got it.
Okay. So that is key, prime. Because you don't just go start treating and say, here, do 20 tongue clicks and this. You don't start implementing random exercises without knowing why it's occurring. And sometimes you have to resolve some of those other factors before you can even start rehabilitating the muscles, right?
Yes. Yep.
So like for my son, when he was about 2 years old, and he developed this persistent open mouth breathing issue. I mean, like lips open wide, lower jaw drop, tongue sticking forward. I'm like, oh my gosh, he can't do this to me. What's happening, right? All of our kids have these same problems. And I put my finger to close his lips, and his lips would just pop back open. And I actually took a dental mirror under his nose and just checked, and his airflow was like a little skinny line. And so I'm not going to put him in myofunctional therapy to get his lips closed, his tongue up without going to the ENT. And the ENT did a lateral ceph, and his adenoids were occupying 80% of his airway. His tonsils were fine, but he had no space to breathe through his nose. So of course he's going to posture the mouth open to breathe. So there's many instances where we don't do myofunctional therapy. Even though we do the evaluation, we refer out till the medical cause of the open mouth breathing is resolved before we treat muscles. All different cases. Same with if a palate is so narrow that a tongue can't fit up there, we might have the patient go through expansion before working to get the tongue up. So key to me is the evaluation. Then,
which I love that. I want to just praise you for that, because when I teach residents, they get so sick of hearing me say it, but I am so hyper focused. And in last week's episode with Trevor Nichols, who's a phenomenal orthodontist, we talked about this exact thing. And the one before that with Courtney Levine, who's another phenomenal orthodontist, it came up again. And it's etiology based. If you just take the time, as you're describing, which takes time, like you're saying, a 1 to 2 hour process, in orthodontics, sadly, it's become this big rush. You go to meetings and you hear, and no knock on consultants at all. They serve a great value. I use them in my practice, but so often it becomes how to speed that process up to get that patient in really quickly. And unfortunately, you end up treating the symptom because you're missing, like what you just said, the etiology with your son was primarily those adenoids. If you're not looking at any of that, now you're literally chasing your tail because you're trying to solve for a problem that you misdiagnosed. And it happens in orthodontics all the time. And I say when I teach this, you don't have to spend an hour on every patient in an orthodontic workup, a bit different than what you're doing when you're looking at it. But the fact that a lot of people are just delegating this to treatment coordinators and not taking the time to really look through all of this, may be fine. And you may get away with it in a certain percentage of cases, just as you might in your field, right? If you start the exercises, there's some people, but you're going to have a percentage of those cases that you completely missed what was really causing it. And by not sending them to the ENT or allergist or wherever you need to send them first, you have really done that patient a disservice. So I think that's so awesome that you are focused on that and take the time in the diagnostic process. And I'm sure that's why you're able to get the results you can. And it's this constant theme, no matter what part of medicine. And how many people like in medicine that have had a medical issue, and when it comes down to it, the first set physician or the physicians, they misdiagnosed it. And it not because they weren't smart enough or capable enough. It seems to be because they were rushed through the system, or the insurance didn't cover that test and it didn't fall into the box that they treat. So everything else ends up falling apart.
Yeah. And people might hate my new patient paperwork, and I have to apologize to them. Be warned, a warning, because I have a lot of questions. So when we see the patient, I almost feel like I know them and know everything about them, where I can almost diagnose them without meeting them. I would never do that, but because I ask so many questions, I even have the patient begin to evaluate their chewing and swallowing. So when they come into the office, they're already prepared to tell me certain things because they're not like, no, what side I chew more on. I haven't thought about it.
Oh, that's
So we
so smart. So you're giving them heads up before they come see you of some things to key in on a little bit.
Yep.
That's
So
great.
they're already thinking about certain things. We ask tons of historical questions, tons of sleep questions, different questionnaires. So that saves some evaluation time because we have a lot of information then. And you mentioned, like, for my son, when he was young was when I discovered he had enlarged adenoids. But before that, I noticed he had this little wound on his thumb. I would know if a kid's sucking their thumb because of that wound, but I didn't see the wound and I never saw him sucking his thumb. But I saw that, like, wound at one point. I was like, why would he have a blister there? This is weird because, I don't see him walking around with this thumb in his mouth.
Yeah.
When he was sleeping, he would suck his thumb when he was asleep. Okay, right? Back then, I didn't know, and I don't know who else knew, that noxious oral habits such as that are a sign of airway obstruction or tongue tie. Okay. Parafunctional oral habits like thumb sucking are a sign of airway obstruction or tongue tie. So I treated the thumb sucking before I took him to the ENT to get his adenoid inspected, before I even knew that, oh my goodness, looking back, like after I learned more of this and this information actually became more prolific, Linda D'Onofrio had an amazing article called Oral Dysfunction as the Cause of Malocclusion. It's amazing. Everybody needs to read it. It's
Can I get a
really
link to
great
that to put on the show notes?
Yes.
Okay, awesome.
Yes.
Thank you.
It's great. And it talks about this in that article, about the airway dysfunction as a cause. Parafunctional oral habits are cause of airway obstruction or tongue tie. So when that thumb goes in the mouth, that thumb is acting like a mandibular advancement device or an oral appliance, like to help open up the airway. So that finger sucking was just a symptom of an underlying airway obstruction. Same with the mouth, open mouth breathing, all this. So this is why the evaluation and being a detective is like the most important thing. I mean, before your patient even steps into your office and you go in the waiting room or wherever to get them, you already have your detective, magnifying glasses on, because you have to really take that part as the most important part. And then the treatment's usually pretty easy, in my opinion. It's not that.
I agree. That's what Trevor and I were saying last week. It's
okay.
Yeah. And all, yes. So go ahead. Yeah.
Yeah, I mean, that's how I feel. So I love doing evaluations because I like that detective aspect of kind of breaking it down. And if we don't discover those underlying components, then not only are we wasting the patient's time and money, but that leads to patient burnout because there's only so much a person can handle, especially if they're not successful or meeting goals.
Good point.
And if they're just continually struggling and not getting there because they have a tongue tie or the palate's nearer or there's, enlarged adenoids that haven't been diagnosed or whatever, then you might lose them forever because you've burnt them out. So that sequencing of therapy and referrals is super important as well.
So what do you advise people? And I have this actual situation that just came up. Someone reached out to me, and it happens to be in the area I used to practice in upstate New York. And she is a speech language pathologist doing oral myofunctional therapy. And she can't find, because in San Diego, I'm guessing you have more, it's obviously more densely populated. You have way more practitioners. This is in a more rural spot of upstate New York. She can't find anybody up there who, in the orthodontic arena or in the otolaryngological arena, who she can refer to for this and will actually address. So when she's doing the workup, I don't know her exact process, but it sounds like when she's doing the workup you're describing, she's detecting these things. And then she's recommending the patient go see an orthodontist or a dentist who does ortho or an ENT based on what she's finding. And they're like, there's no role I can play. There's nothing I can do here. Obviously, if their adenoids are enlarged, most ENTs are going to address that. But if it's some of the more subtle things or sending them saying to the ENT saying, hey, is allergy involved? They're like, no. So she's running up against some roadblocks. So I'm guessing since you've spoken about this nationally and internationally, you've had people ask you this, what do you recommend? She asked me, and I'm like, I reached out to a couple of contacts I had up there, and no one really seemed, again, it's just not their comfort zone to think this way. So what can they do?
Well, I would be really careful not to just refer to like ENT in general and let the patient just find someone, because you might get ENT that's not airway focused
Mhm.
and kind of brush off certain issues. Or if you're working with a patient that needs a tongue tie release, I wouldn't just say, oh, go get your tongue tie released and have them pick whoever. So
Mhm.
I would tailor the referrals to specific referral sources I know understand this information.
And she
Otherwise,
can't,
again,
that her problem was she can't, literally, she's been looking for a couple of years. There's actually a general dental colleague, a friend that we have in common, who reached out to me and said, could she ask? Because, and I practice up there. I know I was the only one that had any awareness in the orthodontic arena. I mean, I was literally the black sheep up there. People like airway, ortho. I mean, it is so, it's hard to believe that this many people are this against this approach, but she's literally trying to find, she's ending up sending them into Massachusetts for like a general dentist.
exactly.
Is the only one she can find. She's like, but it's an hour and a half away and these patients can't all afford to or have the time to drive. So like, I mean, I guess
I drive an hour and a half away. I
Wow.
drive my family an hour and a half away to a specialist who does a technique that I was interested in after doing my research. I drive an hour and a half.
Wow. So this
And
isn't
so,
uncommon, what you're saying. This is a
not
common challenge.
uncommon.
Okay.
Yeah, you have to I think it's important to get the buy-in with the patient to make sure they understand the importance of what you're talking about.
Mhm.
Otherwise, they're going to forget it. I don't care. I'm not going to drive that far.
Yeah.
But once you realize the importance of this and the long-term impacts not treating these issues can cause,
Mhm.
they'll drive wherever to get
Yep.
themselves, or more importantly, their children help.
Yep.
I find in most cases. And yeah, it's not easy driving an hour and a half. I know patients fly to see practitioners. That is not, that drive is, at first it was fun and exciting, and then it kind of drags on
Yeah.
after, a couple years or whatever. But when you know the long-term like outcome and goal, you kind of ignore the little like annoyance of
Yep.
having to go far. But hopefully over time, this won't be as much of an issue because more people will get trained, with this airway minded focus
Yep.
and understanding that aspect. But yeah, it's like, what can you do if there's no one in the area? You have to refer to the person who's closest, and maybe doing telemedicine with a few different opinions. So I sometimes, if my patients weren't referred by a dentist or orthodontist, because I can't refer to someone else if they refer to me.
Right.
But if it's someone who didn't get referred to me, I give them a few different people to say, oh, why don't you get like some different opinions from these people? And sometimes even doing virtual appointments, like even for myself, I did a virtual appointment with someone in Virginia, some like all across, looking over my case as I decided where going to go for my treatment. So sometimes that can help as well. You get your CBCT from an imaging group in your area who then sends the results to the person you're consulting with. I mean, sometimes people need to do that, but it's not easy. And it's frustrating that it's so hard to find certain practitioners in different areas who have these areas of understanding.
Yeah, it's definitely something we need to work on. And what you're doing, you're working on it. I'm trying with this platform and my teaching and all that, but it is an uphill battle. I know I'm going to keep fighting, and I'm confident in having interactions I've had with you. You're going to keep fighting, and I think the more of us that keep fighting for this and raising awareness, I really do believe we can change it.
Yes, right on.
So when they go through that, so let's say you are able to, so you go through your detection process, you make the appropriate referrals. In this case, we'll say they're able to get someone who believed in that approach and was able to help. And then what does your typical protocol look like what are you doing for this patient at that point? Do you have questions about a clinical case, or maybe a challenging practice management issue? Or maybe you're a new doc who's starting a practice and doesn't know where to turn for advice. Doc's private one-on-one coaching platform is here to help you succeed in all these areas and more. Just go to theorthocoach.com and select coaching from the menu to enroll. And now back to today's podcast.
Yep. So then we start the therapy program when we feel the patient's ready. And in most cases, they're ready if they can breathe through their nose. We have a 3-minute nose breathing protocol that's research-based to allow us to know if we can start. But there's all different factors, like I said. When we're ready to start, we start the treatment program, which is kind of like physical therapy of the mouth. So it consists of a variety of exercises, muscle strengthening, increasing range of motion. I believe exercises are the foundation for correct functioning. So in my philosophy, we strengthen the muscles before we work on the functioning and the movement patterns. So we have certain muscular exercises we do for lips and tongue, or if it's just tongue, then just for tongue. We establish correct oral resting posture and then work on chewing and swallowing of foods and liquids and saliva.
Okay.
And that program in our office may take about 8 to 10 appointments to teach.
And are they typically weekly, or is it?
So it's usually for us, it's once a week for like 30 minutes.
Okay.
They'll come once a week. It's about 30 minutes typically. So 8 to 10 sessions, which might, and we just say estimated, it's not always that amount, but estimate about 8 to 10. So like 2.5 months coming once a week. And we guide them through what they need to do at home and progress them in a correct progressive manner. It's not just like random do this, do that exercises, but we work the muscles in a certain order.
Okay.
So we're going to get front tongue, mid of tongue, back of tongue, sides of, like we do a certain order. And then after that, I call that the learning phase, or like the active phase of therapy. Then after that, the patient knows what they need to do. They're practicing on their own at home. They've mitigated all poor habits that are associated with the problem or can influence the way the muscles work. And we check in with that. They have a good nasal hygiene protocol. So we ensure our patients are blowing their nose, using X Clear or whatever to help keep the nose clear. Allergies, if they have allergies, like, so we address all those other components. We also address sleep posture. I address sleep hygiene even with my patients. All these extra components, even reflux, talk about things like that. Wow. And so it's a lot. So after that learning phase, and usually at that point, they're typically getting good oral rest posture, but they're just progressively making progress. It's not like the issues resolved, not at all. They're getting better with exercises. Things might have been hard. And now they're like, oh, this is easy. I can do this. And I like this little saying. It says, actually, I have it right next to me because I was printing up some papers. Okay, it's not going to show, but I'm going to read it. And then I'll tell you the next steps of therapy. It's called the stages of changing a behavior. At first, you are unconsciously incompetent. So you don't know what you're doing wrong. Then with therapy and training, you become consciously incompetent. You start noticing like, oh, okay, my mouth is open. Oh, okay, my tongue is low. Then with much practice, you become consciously competent. You start noticing, oh, my lips are closed now. Yep, my tongue is up. I'm chewing on both sides. Then over time, with much practice, you will reach mastery and you are unconsciously competent. You don't have to think about it and you're doing it correctly. So, and making everlasting changes to behaviors is a process that takes time and many levels of awareness. Be patient with yourself and understand where you are in this process. So I tell patients in that beginning part, you are going from unconsciously incompetent to consciously incompetent, and you're beginning to be consciously competent, right? You're kind of, but then after that learning phase, I'll see you once a month, typically. And that usually lasts for about a year, the once a month session. And then we fade back depending on their treatment reasons. Are they in orthodontics? If they're in active orthodontic phase, I like to stick with them throughout the course of their orthodontics and throughout their retention phase. It just depends on how long they're going to be in orthodontics. And if they're doing great, we might fade back to once every 3 months or once every 6 months. It all depends on the specific case and the reason for the referral. And patients progress at different times and different levels. And sometimes we keep doing check-ins once a year with patients because everything changes with the human body over time, right? Kids might, or you might develop allergies, or they may be seasonal and then you regress if you haven't treated those correctly. Or even like males, there's a high risk of relapse, especially with sleep disorder breathing as they go through puberty because the tongue enlarges. There's a high risk of relapse. So things just change. And I've seen it like with my kids at home. My older son, I thought, oh, we're done. We're good to go. And then the adenoids grew back. And I'm like, what? It can't be. I'm like, now he's having allergies, right? You have to continually be addressing these factors because things might regress. So it's definitely, though, we kind of have a specific sort of protocol of how we do that and tailor it for each patient and their needs. And some patients are have very significant needs and many issues identified in the evaluation, and some don't have as many. So it's quicker and easier to resolve.
Assuming the patient complies in a average to above average way, is the success rate pretty high?
Oh, yeah. Definitely. I mean, depending on all these other factors, right? If they're not resolving
of course,
the
right,
medical
sure,
factors,
yeah,
right?
yeah.
Or
Which is why I love, again, that you have that 3-tiered medical, dental, myofunctional approach, because it makes sense that they would be successful. How do you think that success rate would change, or do you know of statistics or practitioners who don't take that sort of approach, that try oral myofunctional therapy, that have a lower success rate because of that?
I don't know. I don't know about other people and their specific programs. I know we all have the same goal.
Yep.
Or correct, or rest posture, good chewing and swallowing, right? But I would assume that, if you're doing this, then you're going to find yourself successful. And if not, you're going to seek help or ask questions to mentors as to, well, why is this patient not getting better? What's going on? And I find a lot of myofunctional therapists were very passionate about what we do. And people ask their colleagues a lot of questions. I don't think it would be ethical to keep a patient on your caseload and they're not doing better. You have to understand why, if they're not meeting the goals. But I have had patients who either we've had to dismiss from therapy because they're not compliant, because it takes compliance, right?
Yes, sure.
Or we have to let them know that if you don't address the other factors, our progress will be limited. So maybe an adult with a very narrow palate, we'll do the best we can. And you might find that your tongue's not really easily resting up on your mouth. And I remember this one patient, he was probably 13, 14, and he had a significant tongue tie. And the mom did not want to get the tongue tie released. And there might have been a cultural issue or reason for that, but she was adamant that we're not doing a tongue surgery. But I explained to her why and what it is. And we don't need to think of it as a surgery and this whole thing. And I said, well, he had a bilateral open bite due to a bilateral thrust, which that tongue tie was a significant contributing factor. I told her, we're not going to be able to meet the goals. He might be a child that's going to need a jaw surgery in the future. And she was like, fine, totally fine, jaw surgery. I just don't want to cut his tongue.
Wow.
I could never understand that.
That's interesting.
But that was right. But that was an atypical case, but that was a case where success was limited. Because the factors weren't addressed. So
thinking about this and thinking about just how unaware of this the orthodontic community is, and as an orthodontist, I can speak to that. Someone who's been involved in academia for many years, and I consider myself I've been on the forefront of a lot of this. And absent my involvement in the cleft craniofacial team, I really wouldn't even have known much of a role speech could play in what we do, which is sad but honest. So how do we get the dental profession because I do believe that the general dentists and pediatric dentists that I've met and encountered, I've encountered many more of them that are in tune with this and understand this and philosophically line up with this than I have orthodontists. The orthodontists seem to be quite resistant to it, as evidenced by the example I just gave you with someone, back in the year I used to practice and can't find anybody. No one's willing to listen or learn about it. How do we combat that? I mean, I know we could try to get to the schools, but that's obviously going to take time. But how do we show people, educate people? Look what I've done for this kid. Look at the life-changing impact that you have had on this little human. How do we get them excited about that and embracing that and breaking free from those dogmas that are making them say, this is quackery. This is what, exercises for your tongue, give me a break. I'll fix it when they're older with what I do as the orthodontist.
Yeah. It's probably not an easy journey, but that I think what we're doing is helping by having podcasts, teaching, I'm presenting at the American Academy of Dental Sleep Medicine next week on a pediatric sleep apnea, talking about myofunctional therapy. I don't know if myofunctional therapy has been presented there before. The American Dental Association's October 2017 protocol that all dentists should screen patients.
Yes.
Well, I think a lot of dentists might not know what to do, though. So I'm on a team called the Children's Airway Screener Task Force.
Talk a little bit about CAT. Please talk about CAS, because Dr. Simmons and Dr. Carstensen, who we're trying to coordinate all three of our schedules to get them on a show to talk a lot about CAST and really educate people. But if you could just give a quick highlight about that.
Yeah, won't give it away.
Yeah.
So it was Dr. Carstensen helped organize this, and Dr. Simmons is the head of this team. There's about 20 people from across the United States, orthodontists, dentists, a couple speech pathologists, or myofunctional therapists, dental hygienists, Dr. Simmons, and we are developing the universal screening tool that all dentists will be required to use at every dental visit. But this is from a different approach. So there are other screening tools where the dentist or the practitioner evaluates the patient, looks in their mouth, looks for tongue scalloping, looks for large tonsils, narrow palate, things like that. But this screening tool will be a parent tool. The parent will fill this out at every dental visit, and it will be a 5-question screener, yes or no. And if there are a certain number of questions that it'll be like a pass fail, and questions will be like, does your child breathe through their nose or their mouth? And we're just doing the pediatric version of this. One question will ask about behavioral issues. There's going to be 5 questions. So right now we're in the phase where we're doing research to see how valid the tool is. If somebody does not pass the screening tool that the parents will fill out, it could be on an iPad, when you come to the dental office, then there'll be a part B for those who don't pass with more specific, detailed questions. So we're trying to just weed out all the passes versus the fails. And then part of this research is to see how accurate this will be by giving sleep studies to the children to see, could this 5-question screening tool be accurate to help identify kids with sleep disordered breathing? And if somebody does not pass, and Dr. Simmons can go into more detail, but those more detailed questions, it could be that dental office that could evaluate, or if they're not comfortable, they refer somewhere else to evaluate those specifics. So that I think will bring more light to the airway and sleep realm. I mean, most of these issues are apparent in the mouth, right? Most of these issues that are sleep disordered breathing, you can not only talk about behaviors and sleep behaviors and daytime behaviors, but there's anatomical factors that are very visible that are easy to identify, especially orofacial myofunctional disorders can easily be identified in the dental office. So I think dentists is spreading. So then the orthodontists, I don't know how can we keep that spreading? I mean, maybe it's just the more lectures presenting. I'm trying to write some articles and some magazines and like book chapters. Hopefully people will read more information about this. But I think sometimes you can't change people who are stuck in their, dogmatic ways, but new thinkers, more forward thinkers are more adaptable to change. So maybe picking the audience of who we're wanting to listen to this information.
And parents, I think, can play a huge role too. That's where it's so great. You're educating the families and the parents as well. And why, again, the podcast format or any format, you can get it out there in the open, because then the parent sees it. And I kind of use the analogy with orthodontists. And again, being one, I can be hard on us and fair. And I love my profession and colleagues. I try to call balls and strikes on this. And where I see a deficiency, which is in our ability to change and adapt and grow with the times of what we need to do as a specialty when it comes to recognizing these issues in young kiddos and working with all of our colleagues, including speech and language pathologists, to help address them. I really do feel that I have a responsibility to call that out. But if you look at the analogy I use is Invisalign, initially, orthodontists were like, no. Like, you can't move teeth with plastic. No way. It's blasphemous. All these studies on metallurgy, and we've got the perfect wires and nickel titanium alloys. There's no way plastic's going to do that. And fair enough, in the beginning, plastic was pretty inferior. But it wasn't just that Invisalign was getting better results or any plastic, whatever. There's a bunch of different companies now that do it. What happened that really tipped the scale was that the GP started doing it. And so when the general dentist started doing it, that was one big factor. The orthodontist like, oh, wait, they're not sending me that patient anymore because they're treating them. And the second factor was Invisalign marketed to the public brilliantly. And then the public started demanding it. And I was practicing at that time. When I did my residency, Invisalign wasn't a thing. I was actually at UConn. I was in the first class at my third year that actually got certified in Invisalign. It had just come out in the early 2000s. So I lived my practice career through the evolution of moving teeth with plastic. And we didn't learn it in our residencies. And so the other thing was, all of a sudden patients were coming into my office and asking for Invisalign or clear plastic to move their teeth. So I think those two things getting more GPs and the ADA taking a much more aggressive stance on this, which with Steve Carsonson's help and others is great. I think that's going to play a big role, and educating parents and the lay population to understand when they're looking, like you said, what the parents can see this in their kid's mouth. They're noticing these things, helping them realize, like, mom, it's not normal that he can't close his lips together, or mom, it's not normal that he's sleeping with his mouth open or tossing and turning, or all these other things that we don't have to go through all of them. But I think if the parents can demand it and we get jealous of the general dentist taking the patients, maybe, just maybe, then the orthodontist, I can hope, will come around.
That might definitely make some changes. And it, like you said, though, parents being the referral sources themselves and demanding, because there's so much access to information now that it's really easy to not listen to one practitioner. So if you feel something's not right, I think most people don't just accept it now. They'll go and talk to other people, ask questions, social media,
right,
online. And a parent to their child, that's like, probably a parent will do anything for their child. And they're going to try to find the best means. So I think just getting the information out there to the lay public also is very helpful to really spread this message.
Yeah, no, I appreciate you saying that. And I agree. Where can people go to learn more about this? Either contact you, or just if they just want to learn more about orofacial myology, myofunctional therapy. I mean, if they just want to just learn more about it and understand it more, maybe it's a parent who's thinking, geez, maybe this is my kid, or maybe it's a provider, an orthodontist out there who's thinking, I didn't learn this, I don't believe in it, but I'd like to learn a little bit more about this. What resources could you recommend? And I can put things in the show notes too.
Yeah. So for providers, if you're interested in becoming trained or want to know more about this, there's different groups that do different types of training. The International Association of Orofacial Myology, the IAOM, they host different courses. The American Academy of Myofunctional Sciences, the AAMS, or it's also termed AOMT, the Academy of Myofunctional Therapy, they also have courses. Airway Circle is another group that has different courses. So one really great way is there's Facebook groups. The Oromyofunctional Study Group on Facebook has tons of great information where people present cases, or you can ask for like recommendations, like who has the best course, or what courses can I take, things like that. So you can hear other people's opinions on what's helped to them. And there's a variety of different like trainings you could get, but just knowing that it's not one course and you're done. One course is just the beginning. It's going to be a long, ongoing process to keep learning about this. So I think those are great places. Also, Airway Circle, they have really great courses, and they have a great Facebook group and website, and they do every Thursday night. Actually, they do a Thursday night live where they interview other people, practitioners in the community around the world. So they have really good information that they present as well. So there's so many different areas to learn more about that. And then for parents, similar like Facebook groups, Airway Circle. I don't recommend parent groups so much on social media, because, sometimes I read comments, and I mean, as a parent, it's good to hear what other parents are saying, but also know that the information you're getting and the responses you're getting are from other parents and their personal experiences. And it's best to find a high quality provider who really knows the information, because I can see parents kind of may accidentally mislead other parents in answering a question, so just be cautious of that. So yeah, and now, there's a lot of different myofunctional therapists. There's a lot of speech therapists, dental hygienists who practice myofunctional therapy all over the world. So this is not an uncommon thing. This is, I don't even want to say a trend, but there's so many. It's easy. I don't know, easy is a word, but it's pretty easy, I think, to find providers all over the United States, even all over the world, who practice myofunctional therapy as well.
Oh, that's great information. And I can't thank you enough for taking the time. Like that was more than an hour. It just flew by. The amount of information that you packed in, and you did an absolutely amazing job distilling down what this all is, and then talking us through what it looks like for the patient and how they can work with their colleagues. And I absolutely love, as I've mentioned a few times, with that three-pronged approach of the medical, the dental, the myofacial, the muscular side, combining those, the time you spend in your evaluations and I give you a ton of credit for you had a job that you're doing well in your job, and you literally changed the way you approach your entire profession to try to do this and help more people. And it's so admirable. And you are clearly an expert in this, and understand it very, very well, more than really anyone I've spoken to about it. So I can't thank you enough for taking the time to come on and share that knowledge and be willing to distill all that down, because that's what helps people. And then people hear this and they share. It's again the wonder of the podcast universe, right? They can share it with someone else, or they can tell a friend about it. And that's what we have to do to get this message out, to know that there are people like you out there who understand this stuff and can help these patients in ways that they have never heard of them being helped before. So I can't thank you enough for that.
Thank you. And people often refer to the myofunctional therapist as the quarterback of the team, because if we're seeing patients every week for a certain number of months, we can help guide and follow up. And when I train therapists, I say, you're going to nag the patient. Just know you're going to nag. They have not been blowing their nose every day. You're going to ask them every single week, are you taking your allergy medication? You have to bother patients, and they appreciate it. They actually do, because people are so busy in this day and age. And I kind of want to end on this note, but it's kind of a sad note. So if we have a minute, can I tell one little
Please?
story?
Yes.
Okay. So talking about, the guilt, the therapist's guilt. There was a patient that was always on my mind, because I treated this child from preschool for a few years through elementary age. And I completely missed the underlying myofunctional disorder because I did not know about it at this time. Okay. And now he's like senior in high school, but I was done working with him when he was in elementary school. But he had an anterior open bite. Nothing I thought about back then, so many years ago, that it would be related to the work I do. He had large tonsils. He had every realm and facet of a speech pathology problem. He had hyponasal vocal quality. He had a hoarse voice. He had receptive and expressive language issues. So he had a hard time expressing himself, and he'd also forget things easily. So he had a learning disability. And I think he might have also stuttered. He had like everything that fit into every realm. And his mom would bring him in every week for speech therapy. And he'd come in with a can of soda and a candy bar in his hand, because that was her only way she could get him in there. The bribe, when your child's very difficult and there's behavioral issues. And we'd work, do what we did, target all those different areas. But I never treated the underlying cause, because I did not know about it at the time. And like after I learned about this and learned about sleep and airway, I'm like, oh my gosh, I'm sure that kid had like sleep apnea and he couldn't breathe, and all the signs were there, and the open bite and everything. And when there's an anterior open bite and there's a forward resting posture of the tongue, you must evaluate the posterior airway, because the tongue is coming forward to help the person breathe, right?
Yes. Yep.
So I contacted the mom not too long ago, because it's just been on my mind. And she's like, Nicole, you can't help him. I don't think you can help him anymore. His ADHD got so bad that now he's self-medicating and he's doing drugs, and just got kicked out or suspended from high school. And I thought, oh my gosh, lesson learned. We have to get to these children early, because if these problems persist, where are these kids going to go and what's going to happen? So it just was like a really big reminder to me. And like, wow, I missed that. And I probably could have really helped to prevent some of these problems if the airway was treated. So now we know signs are there, so we have to see them. You have to look. You can't turn a blind eye to these things once you know about them.
Yeah, and good for you for persevering and trying to follow up on that, and caring enough to then, and having the ability to be self-reflective, and that's so important to. And this one thing, again, I'm going to be beating on the orthos with this, but it's like we get focused on one way of doing things, and we're not able to say, okay, I get I didn't do it quite as well in the past. I get maybe that wasn't the way, and that doesn't make me bad as a provider. It doesn't mean I was committing malpractice. It's just at the time, that's what I knew. That's what I learned. And I was doing the best I could. But now that I know better, I need to do better, and not just say, this is the way it's always been done. And I refuse to look at it differently. So again, kudos to you for being willing to have that self-reflective approach. And I just wish more people would do that. I mean, I wasn't trained on airway, and I had amazing training at UConn in my program, but we didn't do anything on airway. We didn't do anything on CBCT, wasn't even out at the time. So I didn't know any of that. But as I started seeing more, I couldn't unsee it. I was like, wait a minute, something's going on here. And then as I started seeing these kids I was helping and changing their lives in ways I never knew I could. And straight teeth are great. Beautiful smiles are great. What's that?
Yeah. And no, with the case I just talked about too, like just to bring it all together with that is the hoarse voice was probably related to reflux from negative pressure in the airway
Mhm.
when sleeping with these huge tonsils, that low forward. The learning disability could clearly, and memory issues could clearly be related to a child not sleeping well.
Sure.
And
Mhm.
it's this whole cascade of other problems that I was just doing symptom-driven treatment. So exactly, like, when you know better, you do better. And I think that's how those of us who start learning about this are on that pathway.
Yeah, and it's not comfortable. And I think that people, it's okay to say, like, look, it's not comfortable when you change. It's not easy. It's not easy to make those transformational changes in your practice, not just your mentality, but to execute those changes is also pretty challenging. You have to change your systems and your protocols and your processes. And I think some people, it's just, they kind of just like doing it the way they do it. And it's like, hey, look, I'm not hurting anybody. But that's why that example you gave is so powerful. Because no, by what you did, you weren't, quote unquote, hurting him at that point, right? But you weren't maximally helping him. You weren't helping him the way you could have helped him. And I think so often, especially in the orthodontic arena, it's like, well, what I'm doing is working. I'm getting their teeth straight. I'm giving them a good bite, but we never see them after, a little bit of retainers for a year, or if that. So at that point, they go on and they could go down a path like this kid went that you're describing, and we don't know it. And I think it's incumbent upon us to say, how could I do better to give them overall health, to give them an overall better prognosis for their life, instead of just looking at the teeth and treating the symptom of the teeth and being like, oh, I can put my models on the table and line them up and make it look great. Well, those models are connected to a lot of other things when they're not on the table, when those teeth are in the mouth.
And keep on doing what you're doing, Mike, because for that particular case, I wasn't the only one that missed it, right? There were other people, pediatricians, dentists, whoever else this kid worked with. Nobody probably else obviously picked up on that whole airway component either.
Good
So
point.
just keep spreading the message.
Yes.
You're doing great.
Oh, thank you. I will continue to, I promise, and you do the same. And Nicole Goldfarb, thank you so much for coming on and sharing your expertise and giving us this time. Absolutely awesome. And I really can't tell you how much I appreciate it.
Thank you. I appreciate all you do so much. Thank you.
Thank you. All right. Bye.
Bye.
Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. And remember to join the Doc community on Facebook for more great content designed to help you succeed both personally and professionally. Just go to Facebook, search for the Doc community, and request admission into the group. You can also find Doc on Instagram at @theorthocoach. And always remember, you have been blessed with the ability to do amazing things.